It is my distinct pleasure to introduce you to our invited speaker today, Dr. Nayana Patel is an associate professor and director of the Abdominal Fellowship Program at University of Colorado. Dr. Patel also holds recognition as a fellow of the American College of Radiology and Society of Abdominal Radiology. She completed her residency training at University of Kentucky and then proceeded to complete her fellowship training in abdominal radiology at University of Washington. Dr. Patel's research interests include thyroid and GU imaging, prostate cancer screening, MRI, and percutaneous US guided biopsies for thyroid cancer. Without further ado, I'll pass it over to Dr. Patel. Thank you so much.
Hi, good morning. Greetings from Colorado. Thank you, Daniel, for the kind introduction. I would also like to thank Health for the World administrative team for inviting me to give this talk. It's an honor to be part of the Health for the World team and their effort for the global education. So my talk for today is prostate MRI. As you know, this is pretty broad and huge topic. There is no way I can cover everything about prostate MRI in 1 hour time period. So what I have decided in this talk is to give you the overview of the prostate MRI. I don't have any disclosures. So primary objectives of this talk is to give you guys the overview of the prostate MRI, discuss about the technique and important technical consideration for prostate MR. We are going to review the normal anatomy and important anatomic structures that we can see on MRI. And then I'm going to focus more on the how this MRI can be used and what's its role in the diagnosis and management of clinically significant prostate cancer. So in regards to the technique, multiparametric MRI is the most accurate imaging method to evaluate the prostate and has been validated for detection, localization, and staging of the prostate cancer. Multiparametric MRI refers to MRI that includes anatomic sequences like T1 and T2 weighted images for morphologic evaluation and functional sequences like diffusion weighted images and dynamic contrast enhanced images. MRI spectroscopy is not required and it is not part of the standard multiparametric MRI protocol. The standard multiparametric MRI protocol includes small field of view, high resolution, T2 weighted images that includes prostate gland and seminal vesicles. It has diffusion weighted images with ADC mapping. The diffusion weighted images should include the high B value greater than or equal to 1400. It should also include the large field of view images, T1 and T2 weighted sequences to make sure the images include up to the aortic bifurcation for nodal evaluation. And then it has dynamic contrast enhanced images. So that is typical standard multiparametric MRI protocol. There is another option for MR evaluation of the prostate called biparametric MRI. It is abbreviated MRI protocol, largely similar to multiparametric exam, includes T1 and T2 weighted images, diffusion weighted images with ADC mapping. The difference is that biparametric MRI does not include dynamic contrast enhanced images. The advantage is that because it is abbreviated protocol, it reduces the scan time, and as there is no requirement for administration of the contrast agent, it reduces the overall cost. So it is another good alternative to the multiparametric MRI in the area where the resources are limited and there is limited availability of MRI. Multiparametric MRI is currently the standard protocol to evaluate the prostate gland. In regards to the diagnostic performance of the biparametric MRI compared to the parametric MRI protocol, as you can see, it has pretty similar diagnostic performance in this meta-analysis. So it is a good alternative exam compared to the multiparametric MRI. Couple of things you should know if you are planning to do multiparametric MRI. It is a good option. However, you should consider multiparametric MRI if patient has prior prostate intervention, like ablations, radiation treatment, and you're trying to look at the recurrence. Patient who has high risk history, either because of the high risk family history for prostate cancer or genetic predisposition, those patients should get multiparametric MRI and not biparametric MRI. Multiparametric MRI is also necessary if we happen to do biparametric MRI, turn out to be negative exam, or the diffusion weighted images of the biparametric MRI are suboptimal, then multiparametric MRI is necessary next step if there is persistent clinical suspicion for prostate cancer. Other important technical consideration for prostate MRI are what strength of the magnet we should be using. 1.5 Tesla versus 3 Tesla. Is there added value of using endorectal coil? And what specific patient preparation are required prior to prostate MRI? In regards to the magnet strength, in the literature, multiparametric MRI can be performed on 1.5 Tesla as well as on 3 Tesla scanner. However, 3 Tesla is preferred and recommended. 1.5 Tesla scanner should be used when patient has implanted device which is MR conditional at 1.5 Tesla, but not at 3 Tesla. This is for patient safety. 1.5 Tesla should be used when location of the implanted device is in the imaging field, may cause artifacts and compromise image quality, like hip prosthesis. And you can see that patient has right hip prosthesis, and it causes significant blooming artifacts that can extend in the imaging field, obscuring the gland and the seminal vesicles. So in these cases, you could use 1.5 Tesla instead of 3 Tesla. What about the endorectal coil? So endorectal coil, along with the surface coil, what we call the external phase array coil, increase signal to noise ratio in the prostate at any magnetic field strength and improves the image quality. It is not required, but it does add value for high spatial resolution imaging used for cancer staging, like in DWI, and for high temporal resolution dynamic contrast enhanced images. It is useful in the large patient, and when we are scanning the patient on older 1.5 Tesla scanner to improve the resolution and to increase the signal to noise ratio. New MR scanner with relatively high number of external phase array coils and RF channels can achieve adequate signal to noise ratio without an endorectal coil. And you can see here the picture of the surface coil, and the images, the MRI image we have here is the T2 weighted axial image that is performed on 1.5 Tesla without endorectal coil using 16 channel surface coil. So endorectal coil is not required. It does have some value. And the near scanner with the 16 and high number of elements can give you the similar high resolution images as the 3 Tesla. For the patient preparation, one thing to remember that the hemorrhage related to the prostate biopsy can stay within the gland for a long time, and it can hinder the evaluation of the prostate cancer. So it is advisable to wait for at least 6 weeks or longer after the biopsy, if possible. It is not essential to wait if MRI is done only for detection purpose. The bowel peristalsis can cause motion artifacts and blurring of the images, and some centers use antispasmodic agent to reduce the bowel peristalsis. Similarly, some centers use enema to clean the stool and air from the rectum to reduce the susceptibility artifacts. However, there is no consensus in the literature regarding the use of antispasmodic agent or enema. It is important to ask the patient to empty the bowel and bladder prior to the scan. And here we have an example of the hemorrhage within the prostate gland on T1 fat suppressed images. So it appears high signal intensity, and corresponding T2 weighted images showing the low signal intensity in the area of the hemorrhage. So let's look at the normal anatomy. So the prostate gland has 4 histologic zones. Anterior fibromuscular trauma, it does not have any glandular tissue. It appears as the low signal intensity structure anteriorly along the prostate gland. And you can see that on the T2 axial weighted images, low signal intensity structure in the anterior gland, that is normal anterior fibromuscular stroma. Transitional zone is kind of a bilobed zone that surrounds the urethra. Normally, it has heterogeneous T2 signal. It contains 5% of the glandular tissue, and 20 to 30% of the prostate cancer arise in the transitional zone. Central zone, it surrounds the ejaculatory ducts. It contains about 20% of the glandular tissue, and normally it has low signal intensity. It is seen as the low signal intensity teardrop symmetric structure at the base of the prostate gland on coronal sequence. And along the posterior midline area of the prostate gland at the base on the axial T2 weighted images. Cancer within the central zone is uncommon. Typically, it is the cancer invading the central zone, but arising in the peripheral zone. The peripheral zone, it is the outermost zone, contains 70 to 80% of the glandular tissue. Normally, it has high signal intensity on T2 weighted images, as you can see here in these images. In majority, 70 to 75% of the prostate cancer arise in the peripheral zone. There are other important structure and landmarks that we should know while looking at the prostate MRI. The seminal vesicles located posterosuperiorly to the prostate, they drain into the mid-prostatic urethra by ejaculatory ducts in the region of the verimontana. Normally, they have high signal intensity on T2 weighted images. The dark thin peripheral signal rim is the capsule. It is important landmark to evaluate the prostate capsule. to assess for the extraprostatic extension of the cancer. Neurovascular bundles are low signal intensity tiny foci at the 5 and 7 o'clock position seen on the T2 weighted images. These are the nerve branches of the corpora cavernosa along with the arterial branches from the inferior vesical artery and accompanying veins. They surround the periphery of the prostate gland at the base and the apex and penetrate the capsule, which could be potential route for the tumor extension. Another important landmark is the external urethral sphincter. We always need to look at that and evaluate for tumor invasion anytime we are assessing for the tumor extension and for staging purpose. Okay, so what is the role of the MRI in the prostate cancer? So as you know, the prostate cancer is the most common non-cutaneous cancer in the man in the US. It may have different incidence in other countries, but it is the second leading cause of cancer death in American men. The challenges in the diagnosis and the management of the prostate cancer is that the natural history of this disease is remarkably heterogeneous. The disease is often multifocal. In majority of the patients, the cancer progresses slowly and remains localized to the prostate gland. The detection of this low-grade, low-risk prostate cancer can lead to overdiagnosis and overtreatment. However, the intermediate and high-risk prostate cancer that could be life-threatening are most often curable. So it is important to detect this life-threatening cancer early so that can be treated early, resulting in the cure for that cancer. There are many options for the treatment of the prostate cancer, from active surveillance to the androgen ablation to the local ablative therapy, all the way up to the radical surgery and the radiation treatment. So it is very important to accurately characterize the tumor to select the optimal therapeutic approach given these many options we have for the treatment of the prostate cancer. And it depends on the tumor size, extent, grade, and the stage of the prostate cancer. So ultimate goal of any diagnostic method is to detect the clinically significant prostate cancer for optimal treatment options and minimize the detection of the clinically insignificant cancer to avoid overdiagnosis and overtreatment. The clinically significant cancer is defined on pathology as Gleason score greater than 7 and or tumor volume greater than 0.5 cc and or extraprostatic tumor extension. So with that goal in mind, the PI-RADS steering committee and several working groups with international representation came up with the expert consensus opinion. This document was designed to promote the global standardization and diminish variation in the acquisition, interpretation, and reporting of the prostate multiparametric MRI exam. This PI-RADS document is living document and it evolves as we accrue more clinical experience and scientific data. The PI-RADS document is freely available on ACR website, and you can also dive more into detail regarding the acquisition and reporting system by using this link. So what is PI-RADS? PI-RADS refer to the prostate imaging reporting and data system. The concept is similar to the BI-RADS that we use for breast cancer diagnosis. It is 5-point scale based on the likelihood that a combination of multiparametric MRI findings correlates with the presence of clinically significant cancer in the prostate gland. The PI-RADS assessment categories range from PI-RADS 1, which is very low likelihood of clinically significant cancer, to PI-RADS 5, which is very high likelihood of clinically significant cancer. PI-RADS document has defined criteria on how to evaluate the lesion within the prostate based on the location of the lesion, whether it's in the peripheral zone versus in the transitional zone, as well as the characteristic, the morphology, and the enhancement pattern and the degree of the restricted diffusion. So each of these sequences, T2 weighted, diffusion weighted images, are scored, and then the final score is the combination of the score on these different sequences. So the PI-RADS has a good sensitivity, of 84% for clinically significant prostate cancer detection. So here we have an example of the peripheral zone prostate cancer. So this is multiparametric MRI, and what we have here is the axial T2 weighted image, dynamic contrast enhanced image, high p-value DWI, and the ADC map. And the prostate cancer in the peripheral zone appears as low signal intensity nodule with restricted diffusion that appears as low signal intensity on ADC with corresponding high signal intensity on high p-value DWI and early enhancement. For PI-RADS, DWI, diffusion weighted images, is the primary sequence to evaluate the peripheral zone cancer. This is based on the PI-RADS. This is PI-RADS 5 category lesion, turned out to be Gleason 7 prostate cancer. So here we have an example of the transitional zone prostate cancer. For transitional zone prostate cancer, for PI-RADS, T2 weighted images is the primary sequence. So we have T2 weighted axial image, diffusion weighted image, high p-value, and corresponding ADC map. And what we see here is the low signal intensity lesion with ill-defined margins that demonstrate marked restricted diffusion. The T2 weighted images is the primary sequence for transitional zone prostate cancer detection. Transitional zone lesions sometimes can be difficult to differentiate from the BPH nodules. The cancer in the transitional zone are non or partially capsulated nodule, what we call atypical nodule. They have low signal intensity and ill-defined margins, what we call the erased charcoal sign that you can see here. So we have level 1 evidence and strong support to use multiparametric MRI for the diagnosis of the clinically significant prostate cancer. The common standard is to use the transrectal ultrasound guided biopsy for diagnosis of the prostate cancer. But this PROMISE study, which is level 1 evidence, which was compared with the transrectal ultrasound biopsy with multiparametric MRI in the patients with elevated prostatic specific antigen and in a patient who never had prostate biopsy before. And the study showed that the multiparametric MRI had high sensitivity and high negative predictive predictive value compared to the trust-guided biopsy for clinically significant prostate cancer. Also, multiparametric MRI can improve detection of clinically significant prostate cancer and also reduce the overdiagnosis of the clinically insignificant prostate cancer. In a patient without, in the patient with prior negative trust biopsy, there is also strong evidence in the literature supporting the use of multiparametric MRI compared to the repeat trust biopsy. So the American Urology Association and Society of Abdominal Radiology joint statement actually recommends prostate MRI with subsequent MRI targeted biopsy of the lesions seen with MRI over the standardized repeat trust biopsy for detection of the clinically significant disease. So here we have an example of the patient who had elevated PSA level, negative prior trust biopsy, and due to persistent clinical concern, the multiparametric MRI was done. And what we see here is the low signal intensity nodule in the anterior gland on axial T2 weighted image. And you can see that the exam is done with the endorectal coil. And this was done on our older scanner. Now we no longer use endocoil on our newer 3 Tesla scanner. The lesion has correspondingly restricted diffusion seen as low signal intensity on ADC map and early enhancement. So this was Gleason 7 prostate cancer. And many study has reported that the majority of the MIS cancer with trust biopsy are anterior tumor. And you can see why that the rectum, the trust biopsies are done with the probe in the rectum, and the anterior tumor are located away from this rectum. So there is a risk of missing this anterior tumor, which is really high with the trust biopsy. One thing to remember, not all dark foci on T2 weighted images are prostate cancer. There are certain benign entities and even some normal structures will appear as low signal intensity on T2 weighted images. And here we have some examples. So here we have T2 weighted image with the normal low signal intensity of the anterior fibromuscular stroma and central zone. This should not be misinterpreted as the prostate cancer. It is important to know the structure and their typical location and to avoid the misinterpretation. Here we have an example of the prostatitis. Inflammation in the gland can also appear as multifocal low signal intensity areas scattered within the gland. The hemorrhage within the prostate gland would appear as very ill-defined intermediate low signal intensity areas scattered within the gland. That's why it's very important to check T1 weighted fat suppressed images, as hemorrhage would appear high signal intensity on T1 weighted images. The inflammation and fibrosis related to prior treatment would appear as low signal intensity in the gland. Here we have an example of the patient treated with the brachytherapy, radiation seeds, and the entire gland is low signal intensity because of the inflammation and the fibrosis. The calcification in the gland appears as low signal intensity focus on MR on T2 weighted image. So that should not be misinterpreted as the cancer. Always go back and look at the prior images, and if you see the CT scan, and you can figure out if that area is actually related to calcifications. Also, you can see the surgical clips or the fiducial markers in the gland causing susceptibility artifacts. So this kind of appearance you can see in patient who has prior interventions like ablations or radiation treatment. There are some limitations of the multiparametric MRI. Detecting the prostate cancer in the transitional zone on T2 can be challenging, as I mentioned before, and that's because of the benign prostatic hyperplasia. When there is benign prostatic hyperplasia in the prostate, the transitional zone enlarges and contains multiple nodules. The typical BPH nodules are of mixed to high signal intensity and are very well capsulated, as you can see here in this case. Although there is variation in the appearance of the BPH nodules, as you can see here in this image, the transitional zone is heterogeneous, low signal intensity, with some nodules which are partially capsulated. And in this case, there is BPH nodule is totally dark, low signal intensity, and there is no capsule. This is called stromal BPH nodule, and that's because there is a high degree of stromal tissue compared to the glandular tissue within this nodule. Detecting the prostate cancer in the central zone can be difficult, because central zone normally have low signal intensity on T2. So the only clue you may have is just the asymmetry in the size of the central gland associated with abnormal diffusion and early enhancement. And you can see here in this case that there is asymmetrically increased size of the left-sided central zone extending more laterally, turn out to be cancer within the central zone. Clinically significant prostate cancer can also be missed on multiparametric MRI, and some studies have found that some of these cancers are even invisible on MRI. We also know that the MRI underestimates the tumor size. That can be problematic in some cases, especially trying to select the patient for focal ablation treatment. Multiparametric MRI can also assess for the extraprostatic tumor extension. The PI-RADS criteria for the extraprostatic tumor extension and MRI are indistinct, blurred, or irregular capsule margin, tumor to capsule abutment greater than 10 millimeter, invasion of the neurovascular bundle, as you can see here on both sides, with breach of the capsule and direct tumor extension outside the capsule. Obliteration of the rectoprostatic angle, as you can see here, and invasion of the external urethral sphincter. Here is the external urethral sphincter with the low signal intensity ring, and the tumor is invading the external sphincter. These PI-RADS MR criteria for extraprostatic extension have high specificity and negative predictive value, but with low sensitivity and low positive predictive value. MRI can also assess for the seminal vesicle invasion. Pathologic seminal vesicle invasion is poor prognostic factor associated with increased risk of biochemical recurrence. Seminal vesicle invasion typically appears as low signal intensity within the seminal vesicle and lack of preservation of the seminal vesicle architecture. Tumor at the prostate base that extends beyond the capsule and has low signal intensity within the seminal vesicle is highly predictive of the invasion of the seminal vesicles. T2 weighted images should be used to look at the seminal vesicle. They have high specificity and high negative predictive value. Combination of the T2 with the DWI improves the detection of the seminal vesicle invasion. So we know that now that multiparametric MRI can help with the tumor staging, which is very important to triage the patient for the appropriate treatment option. And you can see here, in this case, the tumor is confined within the gland, so it is T2 stage. In this case, the tumor is extending outside the gland. It's called extraprostatic extension. Here is the tumor invading the seminal vesicle, which is T3b. And here is the tumor invading the external urethral sphincter, which is T4. Here we have an example of the patient with Gleason 8 carcinoma on multiparametric MRI. We see multifocal tumor in the transitional zone. You can see here, iris charcoal sign, low signal intensity notch with undefined margins, extending up to the anterior rectal wall. There is tumor extending beyond the capsule. You can see nicely here in the coronal image with the involvement of the right seminal vesicle. And lymph nodes along the pelvic sidewall in the external iliac chain. It is important to include the entire pelvis up to the aortic bifurcation for the nodal evaluation in your protocol. So, multiparametric MRI is used in different clinical settings, like for diagnosis of the clinically significant prostate cancer in patient group who have elevated PSA and they are biopsy naive, but has high clinical suspicion for prostate cancer. Another group where there is elevated PSA and had prior negative TRUS biopsy with persistent clinical suspicion for prostate cancer. In these two patients group, multiparametric MRI is used and has been validated in the diagnosis of clinically significant prostate cancer. In patients with biopsy positive prostate cancer, it is used for tumor staging, for triaging the patient for appropriate treatment options. Okay, so in summary, the standardization of the MRI technique, MRI interpretation is essential to ensure the high quality MRI exam and for accurate reporting. We know that multiparametric MRI plays significant role in diagnosis of the clinically significant prostate cancer. Accurate tumor staging by multiparametric MRI helps with clinical decisions and guide appropriate treatment planning. Anyone who is interested to learn more and dive deep in the PI-RADS document and PI-RADS criteria, I would refer them to the ACR webpage, which has free access. You can look at the entire document, and I have included that link in the PI-RADS slide. Thank you for attention, and I'm happy to take any questions if you have.
Thank you so much, Dr. Patel, for this comprehensive webinar on prostate MRI. I just wanted to let the audience know that I put the link that Dr. Patel was referring to in the chat box. So if you're interested, please, you can check that out. I also want you to know that now is the time to ask any questions, as we have an expert in the field with us. And I'll give you a couple of minutes if you want. And I do have a question regarding this talk. What would you say is the best way to provide best treatment possible for patients undergoing estrogen replacement therapy in regards with the screening of prostate cancer?
Okay, so are you talking about the androgen deprivation treatment for prostate cancer?
No, I mean more like the patients that are actively undergoing estrogen replacement therapy as their preference.
Sure. And in terms of the, because I assume these patients already have the diagnosis of the prostate cancer, that's why they are on the treatment.
Oh, I mean more for like the patient population that are doing the gender transformation.
Oh yeah, okay, for yes, okay, for that specific population. It is, we haven't, there's not much out in the literature about that, because this is more, it is evolving topic. So currently we don't know how to actually evaluate these patients for diagnosis. We know the current standard screening method for the diagnosis of the prostate cancer are, blood level of the PSA, digital rectal exam for screening, and then for diagnostic purpose is the common is the transrectal ultrasound guided biopsy, which we know is now being I should not say replaced, but a lot of center are using multiparametric MRI followed by targeted biopsy of the lesions for diagnosis of the clinically significant cancer. So this is for more for the normal population that we see. I don't know much about their specific transgender population and how they are being screened in terms of the prostate cancer and what is the how they are being diagnosed. I assume it would be similar at this point because there is not much in the literature. But honestly speaking, I don't know much about that patient population.
Yeah, I agree. This is definitely an evolving topic right now, and it's something that we really have to study.
Yes, absolutely. And it would evolve. And once we have more data, the practice may change for that specific population. But currently, I think it would be similar. That's my assumption.
We have a couple more questions. We have one in the chat box that says, is there a role for transabdominal or transrectal ultrasonography in the evaluation of prostate cancer?
Well, good question. So at especially in US, where the ultrasound is done by the urologist, not by the radiologist. And the transrectal ultrasound guided biopsy is also done by urologists and not by radiologists. So we do not have much data on the role of the ultrasound. I'm sure there is some role, but one thing I can tell you that especially for the transitional zone, cancer detection can be really challenging in presence of BPH, even with ultrasound. There are some newer technique or advances in the ultrasound, like use of ultrasound contrast agent, ultrasound elastography. That may have some role, although we don't use it, so I cannot tell you more about that. But I'm sure there are advances and the role may evolve, and ultrasound may play some role. One thing I can tell you that definitely ultrasound does play a role for the MRI targeted biopsy. And what I mean by that currently the standard at majority of the center are that patient gets multiparametric MRI. Once we review the MR and we find the lesion which are equal to or greater than PI-RADS 3 category, those lesions, we actually label those lesions, and using the hardware or software, we contour those lesions along with the contouring the gland. And this data are actually fused with the ultrasound, what we call the ultrasound fusion biopsy. And then the lesions that we have contoured are then being biopsied by transrectal ultrasound guided biopsy using that fusion. what we call the MRI targeted biopsy or MRI targeted fusion biopsy. So definitely we are using that, and there is great role of ultrasound along with the MRI for the targeted biopsy.
Thank you. We have another question. How do we follow patients with prostate cancer or on hormone replacement therapy and radiotherapy?
Yeah, good question. So that's where actually the literature lacks the strong evidence. We know that there is strong evidence in level 1 studies documenting the use of multiparametric MRI in biopsy naive patients and patients with negative prior biopsy. Patients who already have prostate cancer, who are on active surveillance or androgen deprivation treatment, currently we follow these patients with multiparametric MRI. There is not much role of biparametric MRI in this patient population. Once there is intervention, the entire anatomy and architecture changes in terms of the signal intensity. So the multiparametric MRI is the way to go in this patient population for follow-up of active surveillance in the patient who are on androgen deprivation treatment.
Thank you. The next question is, which is the role of PET in the diagnosis of prostate cancer?
Okay, good question. This is a little bit out of my specialty, but I can tell you that the PET scan, so there are several new tracer, like, Colin PET, PSMA, which is prostate specific membrane antigen PET scan. Then there's Exumine PET scan. And what I know based on the literature and based on from our multidisciplinary tumor board conferences that we have, that PSMA, which is prostate specific membrane antigen PET scan, it is a tracer. PSMA is the radio tracer that is being used for the PET scan. That is the most sensitive in detection for the prostate cancer. Now, these PET scan, they're very expensive. They are not being used routinely for diagnosis of the prostate cancer. They are used for looking at the nodal staging. They are being used to look at the recurrence in a patient who has radical prostatectomy or radiation treatment and now have biochemical recurrence. So those are the specific, clinical indication. That's where the PET scan plays significant role, but not in the biopsy naive patients or a patient with the prior negative biopsy and for simply diagnostic purpose. There is not much role. Also, there is other advance called PET MRI. Again, we don't do that routinely here at my place. I'm sure there are several other places in USA. They are doing PET MRI. Of course, that one has definitely some role because now the PET is done along with the MRI at the same time. So it's looking at the lesion within the prostate gland, looking for the tumor expansion and seminal vesicles based on the MRI, and the PET look at the nodal metastatic disease as well as the bony and distant metastatic disease. So PET MR definitely has role, but it's still evolving technique and not being widely used and not easily available.
Thank you. The next question has to do with the discrepancies seen between the Gleason score and the MRI imaging. These attendees is asking if maybe there's no correlation between the two, or maybe there's another reason.
So sorry, maybe I'm not exactly getting the question, but the question seems like there is a discrepancy between the Gleason score and the PI-RADS score. Am I correct?
I believe so.
Okay.
Yes.
Okay. So so Gleason score, as you know, that it is based on the pathology, based on the grade and the of the the prostate cancer on pathology. The PI-RADS scores is based on the MRI. So the goal of the PI-RADS score is to detect the clinically significant prostate cancer. And typically the PI-RADS score 3 to 5 are what we call the clinically significant lesions that would need further intervention like biopsy to figure out what kind of lesion they are. Having said that, there are some cases of the prostate cancer being labeled as PI-RADS 1 and 2. Small number, but there are cases which are seen as benign entity or completely invisible. The numbers, one study reported like a 16% of the cases being missed on multiparametric MRI on the initial prostate initial evaluation. And when they went back and looked at those MRI, 58% of those cases of that 16% were completely invisible PI-RADS 1 score. So yes, I think partly it has to do with the biology of the prostate cancer. It is markedly heterogeneous type of the tumor, at least based on the few cases that I've seen and also experienced with the rectal cancer, that mucinous tumor, mucinous adenocarcinoma, can have completely different appearance on MRI, being T2 bright. And now if you think that if it is in the peripheral zone itself is bright, high signal intensity, and the tumor is high signal intensity, there is no way you can detect that lesion because they become iso to each other. Now, there is not much restricted diffusion in these lesions too. So I think given the heterogeneous nature of the disease, the biology of the lesion, the prostate cancer can explain some discrepancy, between the Gleason score and the PI-RADS score, So sometimes, the PI-RADS 3 lesion would turn out to be Gleason 8 or Gleason 10, and PI-RADS 5 would be, Gleason 7. So, but the goal here, PI-RADS goal is basically not to minimize the variation in the interpretation and reporting, and accurately detect the clinically significant tumor, which is anything greater than Gleason 6, so 7 and above. Another important thing to remember based on the literature that the PI-RADS scoring does not have high inter-reader agreement. So there is a lot of variability in the way people report, even using the PI-RADS documents. Because it is not easy exam to read. It requires experience. There is a learning curve. So in experience hand, there is a lot more variability, although there is even in the literature that experienced people have only moderate inter-reader agreement. So there's a lot more work need to be done in terms of the standardizing and experience and the way we report the MR exam. One thing, as I mentioned before, that ACR PI-RADS document is a living document. It keeps changing, evolving. The PI-RADS version 2 came out in 2015. The latest version came out in 2019, which is PI-RADS version 2.1, with slight difference in the evaluation criteria for the lesion within the transitional zone compared to the criteria based on the PI-RADS version 2. So now we have more research coming out of those PI-RADS version 2.1 criteria and what is the diagnostic performance of this new criteria compared to the version 2. So it keeps changing, keeps evolving. Once we have more clinical experience and more data, and it will keep changing and evolving in the future too.
Thank you. The next question is, can we certainly or definitely diagnose prostate cancer with MRI without a biopsy?
Okay, my answer is no. You do need pathologic confirmation of the prostate cancer. Now, how that biopsy is done depends on the center to center. At my center, we do the multiparametric MRI and then MRI targeted ultrasound, fusion biopsy of the lesion that we're seeing with MRI. But then at the same time, the systematic 12-core biopsy is done because we know that multiparametric MRI can miss 1/4 of the clinically significant cancer. So it is currently the standard at my place and majority of the center are actually to do the fusion biopsy of the targeted and target the lesion seen on MR along with the systematic truss biopsy at the same time.
Thank you. The next two questions have to do with the post-biopsy scenario. So the first one's going to be, I wonder if post-transrectal ultrasound biopsy changes may not confuse diagnosis of prostate cancer.
Yeah, the hemorrhage, the hemorrhage within the prostate after biopsy can stay there for a long time. It can hinder the evaluation for prostate cancer. However, based on the literature, we know that the cancer is called, the biopsy sparing sign. Means you are going to see the cancer where you not have the hemorrhage majority of the time. So for detection, majority of the time you're not going to miss the prostate cancer because of the hemorrhage. But for staging purpose, where the T2 weighted images are being heavily used to look at the extraprostatic tumor extension and seminal vesicle invasion, that can reduce the sensitivity of the MRI exam if there is presence of the hemorrhage for the staging purpose.
The next question is, how long should we wait for a diagnostic MRI post-biopsy?
Sure. Based on the PI-RADS document, the PI-RADS suggests waiting for at least 6 weeks. But again, I have seen hemorrhage within the gland even after 6 weeks. But that is the recommendation by the PI-RADS. You can wait 6 to 8 weeks. But again, sometimes you cannot wait, and it's okay not to wait if the exam is done only for the detection of the prostate cancer.
Thank you. And the final question is, shouldn't we promote in-bore biopsies over fusion biopsies to retain the procedure with radiologists?
That is a good question, in-bore, there are some centers who are doing MR in-bore targeted biopsy. And there is evidence in the literature. They are more sensitive in terms of detecting the clinically significant prostate cancer. In reality, people who do this, every day, the MR scanner are expensive, So if you, and the MR guided in-bore biopsy takes time, it occupies the scanner for longer time. That means other patients have to wait for their MR exam to be done. So it is not, at least at my institution, the rationale is that it is not a good use of MR scanner to occupy that for hours to do the targeted biopsy. Another rationale to actually not in favor of in-bore biopsy is that we know that multiparametric MRI can miss, the clinically significant prostate cancer. So simply doing only MR in-bore biopsy may not be adequate in terms of the diagnosis and to triage the appropriate treatment. So we actually do MR guided MR ultrasound fusion biopsy along with the systematic core biopsy for the complete evaluation of the gland for diagnosis purpose.
Thank you. That was the final question. Thank you so much, Dr. Patel, for your time, for taking the time to answer our questions. And as a reminder for the attendees, the recording for this session is going to be available in Health for the World website in 48 hours. Thank you.
Okay, thank you, Daniel, and thank you all of you guys for taking time to join me to attend this lecture. And you guys have a wonderful day, good night, good morning, depending on where you are. And it was great to be part of the Health for the World education team.
Thank you so much, Nayana. Thank you for the excellent lecture, and thank you for answering the questions so well. And thank you for all your leadership and great work with the Health for the World University of Colorado chapter. We really appreciate this, and this was an excellent lecture. Thank you so much.
Okay, thank you, Bhavya.
Take care. Have a good day, Nayana. Thank you so much.
You too. Bye-bye.
Thank you. Thanks everyone for joining today. Thank you.
Thank you. Bye, everyone.
Bye-bye.